Good afternoon, everybody. Next topic is how AI can benefit us. And on stage here, we have Dr. Robert Miller and Adam Leiptag. Virtually, we'll have Dr. James White.
Other way round.
Other way round.
Sorry.
I'm James.
Hello there. Okay. So to kick things off here, I mean, I'm a great fan of AI, but my expertise is somewhat limited to playing around with creating funny pictures and editing documents and such like. So we wanted to really discuss. Tell us about how a rare disease is particularly challenging when it comes to diagnosis, and how can AI help address this?
I can start out, but this is a question that all three of us could take in different directions. So, one of the biggest challenges that we find with detecting rare diseases, first of all, it's a very good application of AI because it requires looking at usually very large data sets, right? And so when you're trying to find a needle in the haystack, you need something that can look at all the hay. And so when that is tasked to a human, it almost becomes impossible. So we can't hire a physician to go and look at every health record, every ECG, every imaging test, and then give a call as to what we think the probability that we're looking at a rare disease is. And so first and foremost, it's ideally suited to machines that can do that at scale and very effectively and efficiently. But second, is that you need to teach those machines how to find that needle in a haystack, which means it not only needs to see a lot of hay, but it's actually got to see sufficient number of needles to know how they look different. And so when you think of it that way, it means that you've got to present a lot of rare things to one machine, which means you've got to first have good data. And so the biggest challenge that we have in detecting something like cardiac amyloid is building those data repositories, making sure they're high quality and also represent different disease communities, right? So we don't want to teach it that needle is always found in, Boston, because that's where the disease, that's where we got our data from, because Boston has a different signal than, California or, Ottawa. And so it's about giving enough examples of those needles from different locations. So I'll just start it off there, and then maybe we can have the other panelists add to that.
Yeah, maybe I can jump in next. So for those of you who don't know me, I'll just take a moment. My name is Chris Pettingill. I'm the Chief Medical Officer of an AI company based here in Toronto called Pentavere. We're part of the HealWell family. And our focus at HealWell and Pentavere has always been around preventative care. I'm a clinician by training. When I was practicing in the UK in the NHS, one of the things that I saw constantly, and I've heard about here today from the various stakeholders in the room, is that patients with treatable illnesses, preventable illnesses, are continually falling through the cracks. And what I've seen, what I continue to hear from the colleagues I work with here in Canada, in the UK, in the US, is that this isn't about a lack of data. The data for many of these patients exists. It's being captured by the health teams that are treating them. But the problem is it's siloed. 80% of the data we're creating is unstructured text. These are the letters that you see, the referrals, the lab reports, radiology reports. It's such rich information, but it's captured in these silos, in these buckets. And so making sense of that, particularly for kind of busy clinicians who might only have a limited amount of time, is really, really challenging. And so that's what we do at Pentavere at HealWell. That's our focus, is how can we use AI to sift through that information and get the kind of right information to the right people at the right time, so that we can, shorten time to diagnoses, get patients on the right, or even just move patients along that patient journey to get them the right tests, and then ultimately on the right treatment. This is true, we found, across healthcare, but it's particularly relevant in the rare disease space when, I was a vascular surgeon when I was practicing, so I didn't treat rare disease patients, but what I'm told time and time again is that part of the diagnostic challenge is that these patients, some of you, have symptoms that mimic other, much more rare conditions, and so that's part of the challenge. And that clue for the clinician, who may not be an expert in the particular condition, might be an echo report that's in a different system, or might be in a lab report that's in a third system. And so that's what AI is really, really good at, to Dr. White's point. We can use AI to really scale up the efforts of what any individual physician can do. We can have them look through tens of thousands of records and start to see patterns and to make sense where linking things together. Maybe we'll come on to it in a minute. I don't want to just repeat the points, but it's a very, very valid point that one of the things that you often need with AI is those needles to train it on. And so one of the particular challenges of the rare disease space is when you have so few patients spread across maybe different systems. We could talk specifically about the Canadian system and how it's particularly siloed. It can become very, very challenging. But I'll leave it there for now. Some thoughts to start with. Maybe hand over to Dr. Miller.
Yeah, I was actually going to make a lot of points similar to your last point there, which is I think there's a lot of data out there that it seems like we should be able to find the patients with amyloid out of this. Like we have echo data for a lot of patients, we have ECG data for a lot of patients, but it becomes a bit of a challenge to create these well-curated data sets, especially with a disease like amyloid, because I think the underlying hypothesis we all have is that there's a lot of undiagnosed amyloidosis out there. So if you just take these electronic health records and use it to train a model, it's not necessarily going to learn to detect those patients who are currently undetected. And the flip side of the coin is if you take a very specific data set where everybody's undergone a workup, then the models tend to overestimate because the patients that undergo a workup are patients that have these red flags already. So in terms of how best to balance those two things, I think it's sort of a debatable thing, but that's where the challenge is. And to a point that James and Chris made, there's not just amyloidosis that is potentially out there, there's another 10 or 20 rare diseases that we'd all love to find in the same patient population. So it's about being able to find all of these different types of patients within a large haystack that's actually not sorted and labeled already.
Thank you. So, can you share with us as well, what are some of the most promising AI tools or models currently being used, or are there any?
Mm-hmm. Yeah, so I mean, I think there's a few. I mean, I think everyone's an AI company these days, and I say that as an AI company. But I think we're seeing, everyone's now familiar with ChatGPT and large language models and, kind of what they can do in our kind of day-to-day lives. I think, if you look at kind of the various different repositories of AI models being deployed right now, I was reading somewhere that the FDA currently has a list of around 1,000 approved AI models. These are models that have been validated and have gone through the process. And about 25% of those are in the cardiology space. Mm-hmm. So I think there is a lot of positive movement in terms of what these models can be doing and how they're starting to assist clinicians, other stakeholders in terms of doing better things for patients. Specifically with large language models, we're seeing organizations like Epic, Tempus, all sort of rolling out their own kind of AI tools for clinicians. And so, I think I'll talk a bit more about what the work we're doing at Pentavere Healwell, maybe a bit later, but I think there's a number of different exciting things starting to happen.
Yeah, I think certainly electronic medical record data is a place where you can get a lot of information together, and for that reason alone, it's really exciting. The other way to think about it is there a single tool that a lot of people already have, or at least the patients that have amyloid would have? So some groups have worked with ECGs because almost everybody's had an ECG at some point in their life. And other groups have worked with echo because echo, again, is like a gatekeeper for a lot of different patients who have symptoms that could be related to amyloidosis. So to Chris's point, everybody has their own company and own approach that they're really backing because it makes sense. But truthfully, we don't have anything to differentiate any of those models at this point.
Yeah, I'll just add that, I think one of the things that you can think about is how AI is really affecting the way we're going to do lots of things and along that entire care pathway or journey for a patient. So one of the first steps is doing broad screening, large population screening, in which the types of algorithms that we might use may not have the highest accuracy, but they're trying to put a lot of people into smaller buckets, all right? And then you move down the path and you say, well, how do we take those at-risk patients and make them truly high-risk patients? And that might be another algorithm. And then you actually want a final set of algorithms that are definitive, that are, on the definitive testing, they're improving our capacity to make sure that we made an accurate diagnosis. And so some of the things that you'll hear about is that, yes, we're looking at doing large language models in electronic health information. That can kind of do that first step. Maybe next is an ECG, because that's something that's very common. It's done in routine, visits and annual health checkups. And then echocardiography is usually one of the first imaging tests that we do in heart disease. And then it might go on to nuclear imaging scans or MRI, where both Rob and I love to train algorithms, but that's something that's you're already very far down the pathway. Okay, so I think that you're going to see that there's lots of different approaches that just simply are moving the patient appropriately to that next stage.
Yeah, a recurring theme we hear over and over and over again is the length of time it takes for patients to get diagnosed. So can you share a real-world example of where AI has had an impact in diagnosing someone earlier with a rare disease?
Did you want to get Okay. So we've, as part of HealWell, we've kind of had a number of use cases in the rare disease space, essentially where, as I was saying, we're trying to bring together those various siloed bits of information and present them as flags for clinicians. Ultimately, and we'll probably come to this a bit later, it's always the clinician's decision. We're just trying to present more information for the clinician. We're actually currently undertaking work in the ATTR space. Right now, we're just getting going with it, and we've got some kind of really exciting initial results where we've been able to find some patients that meet those criteria that perhaps should be reviewed. So if we come back next year, hopefully we'll be able to present those results for you and share some direct impact. Outside of ATTR, we've been fortunate to work with and kind of show that the approach works in other rare diseases like PAH, hereditary angioedema, where by finding these patients or finding the constellation of symptoms that these high-yield clinical symptoms, we can present those back to the clinicians as flags. And it's probably, we'll come on to it later in terms of the future, but one thing that's really interesting that we're exploring is how can we allow clinicians to interact with the electronic health record in a more intuitive way so that we're not just presenting one flag, two flags, dozens of flags, but we can actually start to support them as they're going through the EMR. So it's, again, not just for one rare disease, say ATTR or amyloid, but it can be for a whole constellation of them. And, I think we hear at these rare disease conferences that 1 in 12 Canadians have a rare disease, so they're really not that rare. So how can we do better for all the rare disease patients?
Yeah, it's a theme here. Often the disease may not be so rare as undiagnosed. Yeah, underdiagnosed.
Yeah, but exactly. And so, in some of the areas that we've worked in to date, we've seen the kind of diagnostic journey shortened by up to 50%. And hopefully we'll be able to show the same in ATTR as well. Dr. Miller? Yep.
I mean, I can say that I've got lots of interest, but the actual use of AI, I mean, I'm a diagnostician, so I do imaging. And so I'd love to say that we've detected cardiac amyloid by AI, but that's a future dream, right? I mean, so where we are in the pathway of implementing a lot of the tools that we're participating in trying to train is that they're not yet being used clinically. And that's where a lot of innovation is right now, but the trajectory and the speed that which it's developing, I can tell you it won't be that statement in a few years. There are a number of innovations that are getting put through FDA right now, but in the space mostly of the common imaging tests, which would be echocardiography. And so a company called Ultronics, is right now has a very good algorithm for just taking an echocardiogram that can be done in the community and screening it for cardiac amyloid. And so you're going to see a proliferation of these different diagnostic tools to flag patients. And the thing that we're excited about is not just doing it prospectively, but you can kind of unleash it on databases and say, I want to screen every echocardiogram that was done at a hospital over the last 12 months. Maybe we've missed a bunch of patients. So just think of the potential yield that is to be able to run it on thousands and thousands of scans, and then be able to use some intelligent rules to say who should we call, who shouldn't we call. So lots of opportunity ahead. Yeah.
Can I ask a question? Just following up on that, as these new technologies come online, as a practicing clinician, how are you going to appraise them? How do you think you'll assess which ones to implement into your practice, which ones not to? There's so, to your point, there's so many kind of in testing at the moment and are going to be coming online.
Yeah, no, I'd love to get also Rob's opinion on this, but I mean, it's one of the challenges that I think all health systems are facing now is just because you can doesn't mean to say you will be able to, because the infrastructure needs the ability of health systems to assess the technology, appropriately implement it, make sure that they're doing surveillance on the model to make sure that it's actually calibrated to their environment, it's not breaking, and it's not changing over time. Health systems don't have a clue how to do this right now. There's very few programs in the world that have actually set up architectures to be able to do that. And so they do heavily rely on vendors and commercial entities to do that for them. But when a health system is now going to be faced with not just one or two of these, they're going to be faced with an onslaught of these algorithms. The health system is going to have to change and adapt to be able to deal with that.
Yeah, and actually, I think this is a question that a lot of clinicians are going to struggle with, and those of us who do more work in the AI space are maybe a bit more aware of the potential issues. So a very common theme in my work has been you train a model and it looks great in the training data, and then you put it in the external data and it kind of falls apart. So I think that's the first check that we're all going to look for. But to James's point, it really also calls for some sort of prospective mechanism to follow how it's actually working when it's implemented. And certainly, I think in Canada, we're not really well equipped to do that type of work. And I worry sometimes about physicians who have a little bit less expertise in this, because it's very easy to believe that things are going to work really well. So there are some deep learning based algorithms that are built into some camera systems that people deployed without really knowing much of the details of how it was validated. And that was followed up by data saying, well, maybe it's not as good as we think it is. And maybe we shouldn't have been trusting it as much as we did. So I think it's something that you have to have a very good understanding of the data before you start. And then you really have to look at how it's working in your health system once it's deployed. Because something that's trained in Tennessee is not necessarily going to work well in Ontario or Alberta or BC, because our patients are very different.
Right. Thank you. Currently, could you explain in sort of layman's language that a simpleton like me could understand, how is AI actually being used to analyze complex data, such as genomic data, medical imaging, and such like?
Yes, I'm happy to start this off. I mean, the best way to think about how, I mean, there's different types of AI, but I'll just genericize it and say, if you look at how I learn as a clinician, I come to work every day. In fact, when you're doing my training, so I was asked to see a lot of stuff, right? So I was asked to go see that patient, go see this patient, look at these images, look at these ECGs. And, you know, all three of us on the panel here, we just kept seeing patterns, right? So we were like, okay, we've got, somebody told me this was a heart attack, and I look at the ECG. So then I embed that into my own neural network. And if I see that pattern enough, then I've associated heart attack with this pattern on the ECG. It's not dissimilar. When it comes to AI, what it's doing is it's recognizing those patterns. It's trying to have some kind of ground truth told to it, so it's like that expert telling you this is this. And so it does need to understand from good quality data, what we call labels, that's what you're looking at. And it really doesn't matter whether it's looking at electronic health records or an ECG or a medical image. Fundamentally, that's how it's learning. And what it relies on, though, is that the pattern of that data needs to be very consistent between what it's learning and what it's going to then do. So if you just you teach it one set of patterns and then you give it a different set of pattern, it's going to make its best guess, but it's never seen that pattern before. And so, you know, if I were to just look at your table here and say, okay, that thing in the middle that, interestingly, I would have no idea what it is unless it was next to the glass, because it doesn't look like a pitcher of water, to tell you the honest truth. But I know, because there's a glass sitting next to it, that it likely is a pitcher of water. Otherwise, it could be a vase, it could be some creative thing. But it's the water glass that told me that's a pitcher of water. Okay, so now take that pitcher of water and put it on another table without a glass. I'll get it wrong. I'd say it's a vase, right? And so I haven't learned the right patterns to take it out of this environment and be able to do it again. And so that's how AI learns, but it's also the challenge in how AI learns. And I'll let the others kind of take it from there.
Yeah, I mean, from my perspective, that's exactly right. The only thing I would add is just to reinforce what I think we touched on a couple of times already, just the ability, you know, in terms of your question, how does it assist in diagnoses? The ability to bring together siloed data sets, which I guess is, you know, it's as much infrastructure as it is AI, but is really critical and is one of the things that's really challenging within healthcare. You know, we do a lot of work with the hospitals in downtown Toronto, and hospitals on one side of university just don't speak to the hospitals on the other side of university. So even, you know, the infrastructure for a lot of this work doesn't necessarily exist, and so having that put in place, the AI can then bring together the different siloed data sets.
Yeah, I don't have a ton to add. I would just say, so there's two major branches of AI, and I think 99% of the time we're talking about supervised learning, which is certainly what James described really well, which is you show the machine what you want it to do, and then it learns how to do it, and then it does it. The other branch that sometimes people have tried to apply for rare disease detection, or at least phenotyping, is unsupervised learning, where you feed a data set into a model and say, well, tell me what patterns you see without me telling you what patterns are supposed to be there. And that's frequently applied in cardiac imaging sometimes, but the underlying thought being, well, if you tell the machine what to look for, it's going to learn to look for the things that we already look for. But if you want to learn new insights into patterns, then maybe you should just let the machine tell you what patterns it sees.
Right. So what are some of the limitations of the current AI technologies in this space? Are there any rare diseases that remain particularly elusive, even with AI?
I mean, I think... oh, sorry, no, please go ahead. I was going to follow on from your... Okay, I think one of the biggest challenges is exactly to this point around supervised versus unsupervised learning, and we're somewhat constrained still because for the majority of the time we're telling the AI what to look for. And even when we try not to, and I appreciate it's a little bit different with imaging, for example, but certainly with the electronic health record, we're relying on what's captured, which is going through the filter of clinicians who have been trained in a certain way and are capturing things in a certain way, and different clinicians capture things in different ways. We've been discussing earlier on today this work we're doing in the ATTR space, and how a cardiologist would capture things that are very, very different to a neurologist. But both of them, we're limited to what's in the notes, what's being captured. And so to a certain extent, sometimes we'll have conversations around the unknown unknowns. How do you do this unsupervised approach where you can just say to AI, find things for me, find interesting things. But I think at the moment, certainly with the EMR data, we're, for the most part, not really there yet because we're still needing to direct the AI.
I think one other big challenge is we always talk about EMR data like it all looks the same. I think the reality is if you look at EMR data in one health system compared to another health system, it may look very different. The quality can vary dramatically. And just to Chris's point, like some people record things differently in the medical records than others. And like if you look at a cardiology note, we're going to have a great history about how much shortness of breath there is and how much edema there is. But there's going to be very little about sensation, motor function, reflexes. And if you look at a neurology note, it's the opposite. And that's because we all have our own sort of biases. So that makes it difficult to start looking at other healthcare system data. And then it becomes a big challenge for any of these models, especially if you want to start thinking about deploying them in large populations, because you need multiple large, well-curated data sets, and you have to share them between different institutions, and that becomes a bit of a ethical legal dilemma in terms of how best to share data between groups, because we think it's for the good of everybody to have these models work as good as possible and be externally validated and work in lots of different populations. But the practicality of bringing all these data sets together is quite difficult.
Yeah, I'll just simply add that, one of the things that sometimes the people in the AI space will talk about is, well, give us your data and we'll look at it and then we'll assess its quality, but we'll also look at what the signal to the noise in that data is. And so some people would say that the electronic health record has lower signal and a lot of noise. Because people talk differently, they may have different biases in how they put stuff into the health record, and there's also even language barriers. Like on the East Coast it might be more French, and on the West Coast less French, and there's differences there. Whereas on the other side, some of the other medical imaging data and ECG data and stuff has a lot of signal and lower noise, but it's already it's biased by the fact that the patient had to have been referred for it, right? So you've already got a biased group. And so the collective wisdom is coming together to say it really does need to be multimodal. We have to look at all of the data together collectively, and that's actually how physicians practice, right? They don't just look at one of your reports, they look at all of them. They look at your ECG, they look at your imaging, they look at the medical record, and so ultimately that's where we want to get to, but it's gonna take time, right?
Yeah, my dream is just probably pretty unrealistic, is to have a national database where every physician enters his results and then AI will magically say, hey, because of this and this and this, here's a red flag or three, suggesting something, not diagnosing though.
I will say that there are initiatives going in that direction, so this is positive. So there are national initiatives currently being spun up that is starting with just regular electronic health record, but mostly just administrative data, not really the health records that Chris is talking about. But it's starting in that domain of let's share data safely, ethically. It's called federated, so it means that we don't actually send it to each other. We kind of just send our algorithms to each other. But there is recognition of that very very thing being important. And I would say that the majority of Canadians are supportive of that mission. Yeah.
Yeah, that thing you always hear about is, what about my privacy?
Yeah, I mean, I think I've actually just come back from the UK from a summit there, the Shared Care Record Summit. And in the UK, the government has now mandated that I think within 10 years, everyone will have a single patient record. So that's a national program to do exactly what you're saying. And already they have these, it's geolocated, so it depends which area you're in, but they have these shared care records, which brings everything together. So, they are moving in the right direction, and, we hear, I think, to your point, patients are supportive of it here, and we hear a lot about it, but it's going to take, a lot of effort from the ground up and from the top down to really start to see movement in Canada. I think, to your point around privacy, the systems exist now to be able to protect patients' privacy in kind of privacy, we call it privacy first design, and it's multifactorial. So everything from, for example, federated data. We don't need to move the data around. We don't need to take Ontario institution's data and send it to Alberta. The Ontario data can stay in Ontario. The Alberta data can stay in Alberta. And with the right checks and balances, you can have the model, the AI, or whatever the use case is, access it while it stays where it is. You can de-identify data, maybe using a slightly more technical term, but in the AI space, we can tokenize data, so we can break up the data and then just use the bits of data we need that has no PHI, no identifiable information in there. So there's lots of ways to do it, and I think there's a recognition, whether it's the financial sector, the insurance sector, there's a lot of sectors that are moving data around and doing it very securely. And so, the technology exists to do it. It's really, I think it's a will thing now.
Yeah, people's concerns is going to be, again, you hear about often this hugely secure database, like flight control, this type of thing, gets hacked into. How do we ensure that doesn't get breached?
Well, I'll just comment that, a lot of, as was just said, the systems that are being put in place to be able to support these types of models now, they never actually even see PHI or patient health information. So it is privacy by design. So all that the algorithm ever has access to is that there's a pattern of data. I don't know who it is. I know these generic things or tokens about that individual, but I don't know anything else. And so even if the system were to get hacked, as to say, there's no possibility, because the data never was entered into that system that identifies an individual person. And so I think that that's the key, is that, that these databases are not designed to be able to link back to an individual patient by their identification. Yeah.
Anyone else there? No. I mean, so then, how can I say, what are the ethical concerns that drive or arise in using AI for diagnosis, particularly with people that are at risk of developing a rare disease?
I'll start to try to address that. I think James has done a lot of work in this field as well. I think so. The one thing that we all have to be cognizant of is where the models were trained, and whether or not that training population is representative of the population that you want to apply it in. So before I use the example of, well, Tennessee doesn't quite look like places in Canada, but especially once you start looking at applying models in either racial or ethnic or sex-specific groups that weren't well represented in the model, then you really don't know how it's going to perform. And it can do many things. It can either over-diagnose, it can under-diagnose. You really don't know until you deploy and see what happens, which is why it's so important to get this external testing, and as well as looking in a broad group of populations in terms of how it works. So I'll just provide an example from our work. So we did some work looking at epicardial adipose tissue. So that's like the little bit of fat that's around the heart. And we trained a model in a large population that was from a US center. And then we tested it in a couple other US centers, and it seemed to work quite well for predicting risk. And then we started to look at how well it worked in different racial and ethnic minority groups. And what we found is that the values that we were getting and deriving as abnormal were really not representative of those populations. So even when you get a nice internal testing set and an external testing set, unless you actually look in these racial and ethnic minority groups, they're going to be underrepresented in the samples that you looked at, and you really don't know how well they're going to perform.
Yeah, and what Rob's talking about is actually starting to change the design of how we do AI development. And so one of the clinical studies that we've just finished is actually a priori recruited patients from different sites around the world. So what we did was say, okay, how can we get a completely different population than Calgary? Well, let's recruit a bunch of patients that are of Asian ancestry. We went to Hong Kong. And so they recruited a whole bunch of patients for us. Then we said, well, we want African ancestry. So we went to Cape Town, and they recruited a whole bunch of patients for us, and then South America. And so we've actually designed the study specifically for those reasons, so that we can stress test the algorithm and truly be able to describe how it performs in different patient populations. So that's the emerging evolution of how we need to do things, because we're learning lessons from our, historic opportunistic data.
The other thing I would just add, it's the same point, but looking at it from a slightly different perspective, is in terms of access to AI and availability. Let's fast forward a year or two, and we've now got some new fancy models or approaches that are shortening diagnostic times for patients in Toronto. Well, what about patients that don't live in a major urban centre? Earlier on I was hearing about some of the challenges with regard centres of excellence being in the urban centres, and what does someone do if they're 2 hours or indeed 8 hours north of the city? And I think that's something with AI we do need, in ethical AI, we do need to think about. I don't know quite the word, kind of the access, the making sure that in the same way we would with any new kind of a drug, a product, a procedure, an approach, how do we make it available to everyone, to the vulnerable populations, particularly given in a rare disease population, actually people outside the urban centres might be even higher risk of underdiagnosis, or might take even longer to be diagnosed. And how do we make sure we get the kind of the proven, validated models as they start to emerge? How do we make sure we get it so that they're benefiting as well? And then the only other thing that we talk about when we talk about ethical concerns is around the system, the health system. And what I mean by that is we're doing projects now whereby AI is being used to lower the burden on the health system. But we also need to be cognizant of, if in this case we're flagging patients, how do we make sure we're not overburdening the system and that the flags are good? Not in the amyloid space, but we're doing one bit of work in a different rare disease. And part of the existing challenge is inappropriate referrals to the experts and actually overburdening them. And so how do we make sure that those referrals are good? And so AI can help there as well, but it's a consideration we need to think, because of course, in this country and in the UK, we have single access health system or single payer health system, and so we need to make sure we're supporting it and using it efficiently.
Which leads us directly into the next question: is what are the risks of the false positives or the misdiagnosis when AI is involved? How do you manage that?
You manage it by trying to minimize it. It's a huge concern. I think Rob mentioned this earlier. One of the biggest challenges that we think we're going to face is if you start having a lot of false flags or false positives, then you actually immediately start to lose trust as well. So the individuals that are looking at these flags start to ignore them. And that's even worse, right? Is that they don't trust it and they don't act on it. But then also you have to gain trust from the patient. You know, if my physician tells me I think you might have amyloid, and I go, well, that's nice, but I don't think so. You know, show me the evidence. So you know, one of the things that is often talked about but hard to achieve is this concept of explainability in the AI. That, you know, show me why it said that. And you know, so we have different ways that we can try to do that and try to maximize the amount of explainability, but it's always, you know, you're trying to maximize it, not actually achieve it. But I think the biggest concern is, what if I say that I think you're at risk of something, and the only way to confirm it is going to expose you to risk? So let's say I think you're at risk of getting a heart attack, and I think you should have a cardiac angiogram, and then you have a stroke because of the angiogram, and it was always false. It was false positive flag, and there's many examples that you can come up with like that, and so I think that is why we have to have very rigorous testing before we deploy tools, and to make sure that they're being monitored for their performance, and that's really going to be, the onus is going to be on the health systems as well as vendors to be able to do that.
Yeah, I totally agree with all of James's points there. I think there's a burden to the physician. So as it stands, we already got a lot of electronic flags from Epic, and if we start getting a lot of false positive flags for amyloid or Fabry's or any other rare disease, then unless they're all coming back positive and useful, then there's a lot of burnout. Maybe not risk with testing for amyloid, because it's not that hard to do blood work and urine testing to rule out AL amyloid, and pyrophosphate scan is non-invasive, so people aren't going to have strokes from this. But there's also a lot of anxiety that comes with this. Certainly we see this quite a bit as people are referred to the cardiac amyloid clinic, is even if a physician has talked to the patient and said, I'm sending you for appropriate testing, everything is done appropriately, there's always that little bit of anxiety as you wait for test results to come back. And we do see people are quite upset even if they get told they don't have amyloid, just related to that stress of maybe having something that wasn't there. So that's why you always need to be sure about the accuracy, but also be cognizant of how things are implemented prospectively, just to make sure that it's not going to cause undue burden on patients or caregivers or physicians.
The one good bit of news, I think, forget AI for a second, put AI out. These are problems that healthcare and medicine's been wrestling with for as long as there's been healthcare and medicine. It's the same problems for almost any test, screening program, and so I think, you know, medicine or healthcare does have some pretty robust ways to think about this and to adjudicate and judge whether tests, be they an AI flag or a new blood test or a screening test, how they can and should be applied. So I think we're in a good spot there. I think I'm confident that the health system can make some good decisions there.
Yeah, I mean, clinicians are really they're only human at the end of the day. If you get deluged with a whole lot of data, it's impossible for someone to analyze it and make a good decision. So that's where AI, I think, will really, really help.
Yeah, and I think, you know, when we think about, you know, people that say, oh, I'm nervous about using AI, well, you look at the collective risk of not using it versus using it, right? I mean, I think that not embracing the technology and realizing how many patients right now are actually being misdiagnosed or completely missed, the burden on those patients and on the health system is astronomical, actually. I mean, there's estimates of how many billions of dollars the health system actually accrues just simply because of mistakes, medical mistakes. And so AI is going to change things, yes, but the collectiveness is that it will dramatically improve the detection of disease. I have no doubt about that. And that the health system will respond to that in the best way that it can. And ultimately, the checks and balances will be that we save a lot more people, and we do it much more effectively and much more efficiently. So will things change? Yes. But overall, will they change for the better with the adoption of AI? I firmly believe it will.
So, I mean, how do clinicians that treat amyloidosis view it? As they see it as a threat or a tool, or yeah?
I treat amyloidosis. I see it as a tool. I really think it's like everything that we have in our arsenal. You have to know how you're using it. To give you another imaging-based example, so we do pyrophosphate scans, and we know it's highly accurate and sensitive and specific. But even just over the last 5 years, we've changed how we use that technique to improve its accuracy. So it's not necessarily about saying we're not going to use these tools until they're 100% accurate and perfect. I think it's about working with them and trying to leverage them as best as you can. But in a lot of ways, AI is like any other tool that we have in our arsenal for finding these patients. It's a little bit more contentious when we talk about implementing it. If I talk about implementing a new AI protocol, a lot of people would have a lot of questions and concerns, but if I told everybody I'm changing how I do the pyrophosphate scans, nobody is going to talk about that, but they're very similar.
Yeah, I will just, maybe it's a little provocative, but just say, when a new physician starts at your local hospital, they are not assessed for their accuracy, okay? They're trusted, and that person is now your physician. You don't know the report on that physician yet, okay? They've just gone through their training, and somebody has tested them, and now they're treating you. And so what is the bar that we expect AI to perform at? If you're expecting the bar to be your clinician, I can pretty much guarantee you the AI that's going to be released and approved by FDA is going to be that bar, and it'll probably be quite higher. And so we should not expect AI to have 100% accuracy. We expect it to, because it was taught by the best physicians in the world, usually the best data sets in the world, it's going to be better than most physicians, but it's never going to reach 100%. And we need to accept that and say, is it providing me better care than I otherwise would get? And that's the bar.
So we've touched on it briefly, but in sort of 5 to 10 years, what do you think AI will make possible in amyloidosis diagnosis, for instance? Put your thinking cap on.
I mean, yeah, I think, so we've touched on it a little bit. Obviously, the goal is to get patients diagnosed and on the appropriate treatment as soon as possible. Oh, yeah. And so I think that's the direction of movement. Without the diagnosis, all these fancy drugs are pretty useless. Exactly. And we heard in the last talk, just based on some estimates around carpal tunnel, how many patients there might be, or potential patients sitting out there suffering without a diagnosis. So there's a huge need, and that's obviously the direction of travel. I think we spoke briefly earlier about kind of alert fatigue. I mean, I don't know if anyone's walked into an emergency room recently or been in an ICU or anything, and there's just this constant bing, bing, bing. There's alarms going off all over the place, and clinicians do have, I think, alert fatigue. We talk with our primary care colleagues that we're working with, who are trying to engage in some of these programs, but the risk is too many flags. So I think when we look even shorter than 5 years out, what we're really trying to imagine is how do clinicians engage with their electronic medical record in a way that's more intuitive, that brings the information they need to their fingertips, while kind of empowering them to work with the clinician, with the patient. We're working on things at the moment around intuitive conversations with the EMR, so you can ask questions. The clinician can ask questions of the electronic medical record, and the electronic medical record or the AI can make suggestions back to the clinician, kind of bring the information together for them. And so I think that's where we're thinking about the next kind of couple of years, and really start to, because then it's not just about flagging a patient that may have amyloid, but it's about bringing the relevant information for all sorts of conditions. Basically, to me, the vast amounts of data out there, you've got to sort the wheat from the chaff. What's important?
Yeah, and I think that any kind of fears around, it's going to be doing things that I don't want it to do. No, I think it really is going to be designed and used as a consultative process, right? And so that conversation with the electronic health record is basically saying, well, be my advisor. I'm actually going to ask, do you think this patient could have amyloid? And it'll go thinking, right, ... And then it'll come back and go, well, interesting. Well, I've reviewed all of the health record and the patterns of all the blood work over the last 10 years. And, you know, they don't have carpal tunnel and they don't have all these things that I know are associated with it. So no, I think this patient's okay, right? I mean, that's the kind of conversation that's going to happen. And that provides reassurance to clinicians. It doesn't tell them what to do. It gives a consultative opinion. And that physician is still going to have the right to go, no, I still think this. So I think that's the expectation that we all have of how it's going to evolve.
Yeah, to me, the AI should suggest, as you say, not diagnose. Yeah. So, and it leads us to the last question there. What role should patients and patient advocacy groups like this play in helping to shape the future of AI in amyloidosis in particular? How do groups like ours help? Or how can they help?
Oh, you can. So, you know, I think that a lot of programs that are looking at this, both commercially and academically, they are very much aware of the need to engage patient groups and ensure that, and I think that this has actually come more to light with the era of AI, is that, you know, to ensure that there's fairness, there's equity, you know, the bias, things that we know about bias are informed by patients saying, well, would it work on me? Because I'm different. And you need to hear why, okay, why are you different? Tell me why you think you're different. And that's what leads to, those moments where you're like, yeah, we never considered that. It may not work for you. We've got to test that. And so I think that all the groups are very interested in, because they don't want their algorithms to fail. Can't afford it. And so I think that there will be opportunities. I think make it aware that you are available for these opportunities, and I think you'll be engaged.
Yeah.
So I agree with that. The other thing is, we've talked a lot about screening, but there's a lot of other things that may be important to patients with amyloidosis that we should know about. So, like I do some work on using AI to help interpret pyrophosphate scans or quantify them. And we could use that to predict risk. But then maybe we could also be thinking about, well, can we use this to help choose treatments for people? Because I'm not at the meeting, but I'm sure there's lots of discussion about the different treatments that are available. So I think it would be a very different approach for a lot of us if patients came to us and said, well, actually, the number one important thing for us is tell me that drug X is going to work for me better than drug Y. Or tell me what the best way to make me feel better is. Like, what's the best treatment for me? So I think knowing what the patient priorities are is really important for all of us in industry or research or really clinicians. It's really important for us to know what's important to you, because we often see people in clinic and we get through 5 or 6 symptoms, but then it usually comes down to, but what's the most important symptom to you? What do you really want me to focus on and try to make better? Because sometimes we can't address all of them at the same time. And for research, it's the same thing. We can't necessarily address all of the questions at the same time, but if you told us which question is most important to you, then that's where we can focus.
Yeah, and just to reinforce that, I mean, the way we think about it is that you should be setting the priorities. Really just repeating what's already been said, but there's so many stakeholders within the health system, but ultimately the one that matters is the patient. And so, we can pontificate in fancy boardrooms about what we think might be important or what the market might view as valuable, or even institutions or clinicians, but ultimately it's the patients that need to be setting the priorities across the board, whether we're talking about AI or drug development or, ultimately we need to be listening to the patients.
Yeah, and there are huge investments being made in AI right now. It's just, obviously it is the way of the future. But yeah, it's got a long way to go. So we have a few minutes left. Open the floor to questions.
So along the heading of perhaps under the heading that you have to walk before you can run, personal experience, went to see a new specialist. He opened up my government portal. He did not have my MRI. He did not have my echocardiogram. He did not have my specialty blood test. What common theme is they're under the provincial umbrella, but they're contracted out. Dr. Miller, Dr. White, I see you're from Calgary. Do you have confidence that the Alberta health system can give your wonderful AI algorithm the information you need? And then can we help you get it? I think how can we help you get that information?
Yeah, so I can definitely speak to that because that's actually my mission. So as Director of Precision Medicine for the Libet Institute, this is my job, actually, is to try to make sure that data becomes accessible within the Alberta health system to be able to develop and validate and deploy these types of models for Albertans. And so being charged with that responsibility, we are working actively with Alberta Health Services and the ministry to be able to facilitate that type of data integration securely and safely for Albertans. And we've made a lot of headway over the last several years. We've formed a new center, which is called the Nelson Pulse Center, which was just recently announced with an investment of $12 million. This is all dedicated towards the very mission that you just said. So we're working on it, and hopefully over the next couple of years, you'll hear that Rob and I have actually started to achieve some of the goals that we have aspired to. So we're working on it.
Please come and talk to British Columbia.
We will, yeah. No, we'll be happy to come over and talk to BC.
I was actually just going to ask this is probably the same follow-up question. In my experience, Alberta does seem to be head and shoulders, dare I say it, above some of the other provinces. Is there much knowledge sharing or learned experience sharing? Because I think some other provinces, maybe BC, I don't know, could learn from Alberta and the amazing things you're doing.
Yeah, we've been both lucky, and alignment is everything. So what we've discovered is that there has to be alignment of agenda across multiple pathways. So it has to be that you've got champions on the clinical side to drive it. You need data science. You need the people that can develop the tools, but you also need buy-in from the provincial government, and you need buy-in from the data custodian, which is the health system. Getting buy-in from all those people at the same time is a feat. And what a lot of other provinces face is that there's multiplication of all those complexities because they have a health region here, a health region here, a health region here, and so everybody's almost doing it at a hospital level, whereas when we engaged on this process, we're able to do it at the provincial level. And so that was the advantage in Alberta. It made it actually harder because every decision takes much, much longer. But when you do make it, it gets done at scale. And so, the path is still long and, arduous. But I think that because we've been able to get those different players to talk to each other around that mission, I think that and we have actually published a framework that got published earlier this year of how we went about doing that, and it can be used as a template for other provinces.
Just a quick question. Hopefully there's an answer to it, I'm not sure. In terms of globally, is there anyone using AI to do not diagnosis, but to use AI in terms of amyloidosis or any other rare diseases? Is there anyone in the world that's at the moment using?
Oh, yeah, like, so other places that have actually implemented and are using. Certainly in the research setting, because there's been clinical trials that have been using it. So the things that we mentioned before about ECG and echocardiography, and there's been EHR data models as well. So these, I think that it's going to be hard not to use it soon, because the evidence is so powerful that it actually will be that if you're not using it, you're not meeting care guidelines, right? I honestly think that that's what will happen, is that the evidence will be so strong that health systems will actually start to say, we can't afford not to do this. But I think we're just in that transition phase right now where the evidence is getting out there.
Thank you.
The only other thing I would add is globally, I think you see greater adoption where there's, I guess, a more homogeneous access to data or less kind of siloed data. I've been fortunate enough to meet with a number of representatives from some countries in the Middle East, like Saudi Arabia, and they do seem to be a little bit ahead, just because they have a single patient record for every patient in the country. It includes all their data. I mean, we can start to talk about, ethics and privacy, but it's quite remarkable what they're doing, and because they've got that access, they do seem to be a little bit more advanced.
Yeah, agreed. And I was just talking to somebody from Denmark, similar. Denmark, they've got one health system. In fact, they've even linked all of their health data to all of the other data. So social services and education and things. So they actually have one identifier for every person in the entire country. And so it's automatically all linked. And they've got a process where each individual can log on and access all their data in one place. It's brilliant. And they've built all the ethics around it and the governance. And so, those types of countries can implement things at scale so much quicker than in, other countries where it's all isolated and siloed.
So what's stopping the likes of Canada from doing something like that?
Well, I guess every political will, budget, it comes down to usual things.
Multitude of things.
Yeah, there's many challenges, right? But that being said, I mean, there's multiple opportunities as well. So I can tell you that, talking to different people in different locations and stuff, like certainly they're jealous of what's happening in Alberta, which is great. But there is opportunities across Canada that don't exist in other health systems because we are public. There is a different perspective on how data can be, accessed and used. And I still think that Canada is in a good position to be able to execute these things. I'm optimistic, but it is certainly more challenging than in some of the other countries that 20 years ago they started thinking about these things, right?
I do hear as well globally that Canada, one of the reasons Canada's in a good position is strength in our diversity. It's such a diverse population. With a robust health system, and so it kind of puts us in a position where there is real interest and there's real opportunity there.
Although I did recently hear that we were rated as far as AI readiness. Our data resources were considered among some of the best, but our AI readiness was scored as one of the lowest. So it's the delta between those two. It's the opportunity versus the capacity. But many countries face the same thing. So our readiness needs to be improved, and that is a lot of the things that we were talking about infrastructure, health systems talking to each other, bringing together multimodal data. That's the investment over the next 5 to 10 years.
Any more questions?
Yes, please. I would like to thank the panel for their insights. The last two comments kind of spoke closely to what I've been reflecting upon this whole discussion. Basically, data appears to be key for the advancement of AI. Really, my question is to better understand who owns the data. On one hand, as a patient, I'm told that I own my data so I can get all my records from all the different providers. I've heard the term data custodian, which would seem to allude to me that some organizations that have my data have certain control rights, but that ownership piece seems to be a bit nebulous.
Yeah, sorry, I seem to be talking a lot, but it is something that I face a lot in my position, is discussions surrounding data custodianship versus ownership. And the term custodianship really is more equated to privacy and control, meaning that the custodian has incentives to not share your data because of privacy breach. And their biggest concern is that if I let even one record out, I'm going to be put on the front page of the newspaper as a health organization. And so there's no incentive for the health system to share your data with industry, even with you, because they worry that that could lead to a leak. Now, they can share it with you because if you request it, it's your right to get it, okay? But when it comes to actually supporting AI, it's everybody would have to request it all at once to say, I want it to go here. So to get access to at-scale data to support development and implementation of AI, then the question is, what does the custodian do? And to date in Canada, the prevailing message has been, it's safer to just not. Right? And so that means that governments, that means that custodians will err on the side of locking all the data up and not allowing even academic researchers ready access to it, which has been a huge problem for innovation in Canada versus other jurisdictions. That's why the US and other countries are escalating their efforts rapidly while Canada is falling behind, I'll be honest. So what has to happen there is adoption of new regulatory changes to say it is safe to share under certain circumstances, and we need to lower the barrier for privacy and start to increase the penalty for not using data to improve care. And that's a complete shift in how we think about risk. It's not just the risk of letting data out, it's the risk of not using it for patient benefit. And right now, that is skewed towards risk aversion and not sharing data for innovation. So I'll get off my soapbox now, but the bottom line is that it's a problem at both provincial and federal level, that the penalties for sharing data are perceived to be too high to accept the risk of innovation currently in Canada. It's shifting. I'm not saying it's not shifting, but it's not shifting fast enough. You know, my feeling is that there are, as mentioned earlier, there are now very safe, secure ways to be able to train these models to use patient data to be able to improve care. It's not the same as 10 years ago. It's not the same as 20 years ago when these privacy regulations were put in place.
And I will say that, you know, if we don't continue to move forward quickly, it's Canadians that are going to suffer. You know, I'm fortunate to be part of a global organization, and other countries, the US in particular, are moving more rapidly, and it's, you know, it's becoming, you know, comparatively more challenging to work in Canada, and it will, you know, it's only going to hurt Canadians in the long run. And, you know, obviously I'm from the UK, but we're a Canadian company, and we want to be benefiting Canadians, you know, Canadians first. And I just want to clarify one point as well that may be different to AI in other industries. Despite sharing data or using data for different purposes, an AI company would never take or should never take ownership of your data. It remains your data. You know, the health information custodian is still the custodian. The AI company will do whatever they're doing, but it is never our data. It should never be our data. You know, we believe that very, very strongly at Healwell, and, you know, any company that's operating under a Facebook model and trying to own your data or monetize your data, as you're all going out there and talking about AI and hopefully sitting on panels and hopefully engaging in this conversation, you know, be very, very suspicious of them. The AI company should not own your data.
Just following up on your comment that we have very unique data, which is a great advantage for us. It's multicultural and very diverse. Following up on your other comment that says that training the data on the data that we're going to be using is very important. If we don't address the interoperability, the sharing of data, then how can we trust the models that come out of what you're doing now? Because I'm not sure what you're training the data on. You know, the data is not diverse. We don't have access to it because of the interprovincial problems and so forth. So I mean, you mentioned that it's a risk that we're falling behind, and is that one of the main areas that we're falling behind on because we're not getting access to data that is truly representative of our population?
Yes, I mean, that's definitely one of the risks. I think, you know, we heard earlier about examples of having to go globally to get, you know, various representation. You know, even just keeping it a bit more local. All the work we do, we have to be very thoughtful, put a huge amount of effort into ensuring that we're getting a representative population, which means, you know, from different provinces, urban, rural, you know, kind of different demographics, for example. So it is a challenge that needs to be kind of built in and addressed upfront in any particular engagement. But, you know, to, again, maybe be provocative, but to go back to your first comment around, you know, if we can't address this, how can we trust the models? Well, we can't, you know, and I think it's a point that's been made a number of times that the models are kind of as good as the patient population they've been trained on. I think I alluded to it, you know, we've been working in the ATTR space in the cardiology setting. If we want to start looking at the neurology setting, we really need to train models on neurology patients. So it's critical to be able to address that, and that is one of the big challenges, you know, within the Canadian healthcare system.
Yeah, I'll just add to that there are opportunities for health systems if they have that readiness that I was talking about, that when a new model is coming in, even from a vendor, maybe it was trained in, you know, Israel or France or somewhere like that, that if they've already prepared their data appropriately, they can run the model and see if it's calibrated to their population. Did it predict what we think it should have? And if not, then, hey, we've already prepared the last 10 years of our data. Can you do a retraining or a refinement on that model and fine-tune it on our population? And so that's the alternative solution that we can have, and that's what we're aiming to implement and are implementing in Alberta, so that if there is, you know, if Pentavere or HealWell come and they say, we've got a fantastic model, we'll go, okay, wait a sec, let's run it, because we've got our servers set up with, you know, 1 million patients sitting there, so we run it and we'll see how it performed. No, it didn't. I want you to retrain the weights of that model on our population, then we'll retest it. Okay, now you can use it. And so that's a different approach. But that means that you have to have good readiness. That health system needs to have thought ahead and prepared for that circumstance. But ultimately, what we would love to do is that these innovative companies and our own innovation within Canada is training off those data resources properly, pan-provincially, right? That's what we should be doing, because we have 3 of the best AI institutes globally in Canada. So as far as the minds to do this, we've got the best minds in the world. And there's no reason whatsoever that those institutes should not be using Canadian data to actually innovate and bring healthcare AI to our own people, right?
Anybody else? If not, then I think it's 15 minutes past closing time.